Hello, welcome back, and thank you for joining me again. Today we're going to talk about a really practical topic, clinical decision instruments. I chose this topic because it applies to something we do a million times every shift, make decisions. I developed this idea for a talk after spending some time working with learners and staffing patients in the ED. Using a clinical decision tool seems really straightforward, but it turns out that there are a lot of ways that this can go wrong. And applying these tools correctly isn't quite as simple as one might think. So I wanted to spend some time talking about clinical decision instruments to help people understand how, when, and why we should, or in some cases, should not use these in our practice. Today we're going to talk about what a clinical decision tool or instrument is, and we're going to recognize when decision rules are appropriate and when they're not. It's important to understand how to apply these tools effectively, and then we'll talk a little bit about some of the pitfalls that can happen when using a clinical decision tool. What this is not going to be is a discussion about specific decision instruments. This talk is designed to help you understand how to apply a broad variety of clinical decision tools. And while we will talk about some specific rules to illustrate examples of specific concepts, we will not be delving into an in-depth discussion of each of the specific clinical decision instruments. For our mental breaks today, I thought it would be fun to post some warnings from some creative thinkers who aren't afraid to think a little outside the box. So, what is a clinical decision tool? These are typically sets of clinical criteria that have been developed to answer a very specific clinical question with a high degree of certainty. These are typically evidence-based, and good clinical decision tools have been externally validated in multiple populations to ensure that these work to help you manage patients quickly and safely. Many of you are probably already using these in your practice, with some of the most common examples we use in the ED being things like the PERC rule for pulmonary embolism, the Nexus criteria for C-spine clearance, and the Canadian Head CT rule for low-risk head injury. Contrast this with a risk stratification tool. Risk stratification tools were developed to help you estimate a patient's risk for a disease process, but were not actually developed nor prospectively validated to actually rule in or rule out the disease. Often, these are developed for more complex and more heterogeneous disease processes that aren't really amenable to a clinical decision tool. For example, sepsis is a very heterogeneous disease, which can be caused by multiple different types of infections, different bacterial etiologies of varying severity, and it can't really be managed as a one-size-fits-all process. Despite the fact that we've known about sepsis since the era of Hippocrates, we are still to this day struggling to define exactly what sepsis is. That's why things that we've tried, like the SIRS criteria and QSOFA, have all performed dismally at reliably identifying sepsis. All they can really do is identify individuals that are sick, and therefore help you risk stratify a group of patients who are more likely to have the disease. Some examples of risk stratification tools that you're all probably quite familiar with include the Wells score for pulmonary embolism, QSOFA for sepsis evaluation, and the HEART score for evaluation of low-risk chest pain. As you know from your clinical practice, there are basically two types of testing strategies that we use: tests to rule in a diagnosis and tests to rule out a diagnosis. Tests with a high degree of sensitivity are best for ruling out disease, whereas tests with a high degree of specificity are the best for ruling in disease. The overwhelming majority of clinical decision instruments are rule-out tests, as they are designed to have a high sensitivity. What these types of tools are designed to do is help you minimize testing in large groups of patients that are at low risk for a specific disease process, by taking patients that are at low to moderate risk and applying a set of validated criteria that shifts them from a low-risk group into a very low-risk group. Notice that I didn't say no risk. There's really never any such thing as no risk, but assuming that patients meet the criteria in the decision tool, they are typically low risk enough that the chance of getting a false positive is actually higher than getting a true positive should you go on to pursue further testing. So you're actually more likely to do harm by doing further testing than do good in that very low-risk population. Clinical decision aids can be helpful for a number of reasons. I don't know about where you practice. I know where I work, it's a very busy suburban ED that's also a level 1 trauma center, a stroke center, a neurosurgical center, a cardiovascular center. So there are times when ordering something like a CT scan can easily take 4 to 5 hours from the time it's ordered to the time it's actually complete. So if I can obviate the need for advanced testing in some of my patients, I can save huge amounts of time by decreasing the number of tests we order. So not only are we decreasing the need for diagnostic tests, but we're also decreasing things like unnecessary radiation exposure for the patients, decreasing my length of stay, and also decreasing the costs of care. And hopefully, by doing some of these, we can also translate that into higher patient satisfaction. I'd like to spend a minute talking about how clinical decision instruments get developed, because I think if you understand how these tools are developed, it will help you understand why it's important to know how to apply these correctly. So the first step is to ask a clinical question, and the narrower the question, the better your clinical decision instrument is likely to be. Step 2 is to review retrospective data with which to derive the tool. Step 3 is to prospectively validate the tool in multiple populations. And step 4 is to assess the impact of the tool on clinical practice. So step 1, ask a clinical question. The best clinical decision tools were developed to answer a very narrow and very specific clinical question. I think it's easiest to understand why this is true if we look at a couple of examples. Let's look at the Nexus tool for cervical spine clearance. This decision tool asks the question, in patients that have sustained blunt trauma and are complaining of neck pain, which patients require imaging of the cervical spine? This is a very specific question, which is why they were able to identify the 5 clinical signs and symptoms that allowed them to achieve nearly 100% sensitivity and specificity for cervical spine injury. By contrast, people have been trying to come up with a clinical decision tool on which syncope patients can be discharged from the ED safely for decades. The problem with this is that syncope is a very heterogeneous disease and is the final common pathway for a whole host of potentially serious causes, such as cardiac dysrhythmia, pulmonary embolism, severe aortic stenosis, ruptured ectopic pregnancy, and so on, as well as potentially benign causes like mild dehydration or vasovagal episodes. That makes it really difficult to come up with a single set of criteria that will reliably exclude serious diseases, and is why tools like the San Francisco Syncope Rule have repeatedly failed in their validation cohorts. Step 2. Derive the tool or instrument. Deriving a clinical decision tool is a process that involves looking at huge sets of retrospective data. Basically, you're looking at data sets of patients evaluated for a specific disease process and looking to see what clinical characteristics or simple tests did all of the people who ruled in or ruled out for a disease process have in common. If you can find a few things that seem to differentiate the groups with a high degree of sensitivity and specificity, then you just might be onto something. Next, after you have found the clinical criteria that you think will separate the sick from the not sick, you apply it to a new group of patients in prospective fashion and see if it works. Ideally, this should happen in multiple populations that are both ethnically and geographically diverse in order to make sure that the tool works in all of these different populations. This is where a lot of clinical decision instruments that are derived retrospectively ultimately fail. After you validate it and figure out that your clinical decision tool works, awesome!
And there was much rejoicing.
Well, the final step that unfortunately frequently gets omitted after the instrument is clinically validated is to ask the question, how does this and should it impact my practice? It's great to have these tools to work with, but we need to ask whether using them is actually going to help us do what we set out to do. Is it actually reducing time in testing? Surprisingly few clinical decision rules that have been developed are ever compared head-to-head with plain old physician judgment, which is really what we want to know when we're using one of these. Will it actually improve upon our own gestalt? But much of that time, the question is never asked. This is a paper that was published in the Annals of Emergency Medicine, and in it, the authors did a prospective evaluation of clinical gestalt versus the PCARN, Chalice, and Catch clinical decision rules for kids who bonked their heads. Basically, all of the physicians just made a clinical decision about whether they thought that the kids they evaluated needed a head CT based on their clinical gestalt. And then a researcher applied all three of the decision tools to the same patients. They enrolled 18,913 kids with mild head injury, defined as a GCS of 13 or greater, who presented within 24 hours of the injury. Of these, 1,579, or 8.3%, got CT imaging, and of those, 160, or 0.8%, had a clinically important injury on CT, and only 24, or 0.1%, required neurosurgical intervention. So, how did the docs stack up against the decision instruments? PCARN was the most sensitive, missing only one injury on the first visit. So it was 99.6% sensitive, but also would have scanned or observed more kids than any of the other decision rules. On the flip side, Chalice and Catch only caught 91 and 92% of the injuries, which is probably why none of us have ever even heard of those decision aids, because they're just not sensitive enough. PCARN clearly won the battle of the decision aids. However, it was the physician's gestalt that actually won the day. The physicians picked up 158 of 160 injuries on the initial visit, with the second two injuries being found on the second visit, and neither of them required any surgical intervention, for a 98.8% sensitivity. So I think that we can say that the PCARN tool worked because it was the most sensitive, but I don't think that we can say that it actually outperformed clinical judgment. Now, before you flip the table and decide that I've wasted the last 30 minutes of your lives, there are some big caveats we have to consider in this paper. First of all, they started out with a really low rate of CT usage in the first place, much lower than what we typically see here in the United States anyway. This study was done in pediatric EDs that were staffed by pediatric emergency medicine specialists that exclusively see kids. And it was done in Australia and New Zealand, where they have a much lower rate of imaging than we do here in the United States. Sometimes it seems like here in the US, the only criteria we use in deciding who gets a head CT is whether or not the patient has a head. So it's entirely possible that if we repeated the same study in the United States, or in EDs that see both adults and children, that the amount of testing would actually substantially decrease if something like the PCARN tool was applied. All other discussion aside, this paper is just a great illustration of why it's important for us to ask the question of when and if clinical decision aids are an improvement over clinical judgment. Ultimately, the answer to this question for the individual physician really comes down to it just depends. At our site, we have docs like me who order testing a little less often than some of the other docs who perform tests on substantially more of the patients they see. For someone who is comfortable and confident in making decisions based on their clinical skills, using a decision rule could very well result in an increase in test ordering. But for someone who is maybe less confident in their clinical skills, or for residents or students that are still developing that clinical gestalt, this may actually help decrease testing, and it can also help those newer physicians build those mental maps and develop that clinical spidey sense that helps them with those decisions in the future. I use these to support my clinical gestalt. If I'm a little on the fence about something, one of these clinical decision tools can help me by supporting my clinical gestalt, or by helping to give me a nudge in one direction or the other. They're also useful for charting. For example, I can just say, quote, based on the PERC instrument, this patient has a pretest probability for PE of less than 2%, therefore further testing not appropriate. And I'm done. The bottom line is that clinical decision instruments should be used to support your decision making, and not to make your decisions for you. Let's move on to talk about some of the pitfalls that can occur when applying clinical decision instruments to your patients. One of the biggest pitfalls of using a clinical decision tool is that you need to know who the tool was developed for and validated in. These tools have been developed to answer very clear and very specific clinical questions and in specific populations. So, for example, if the tool was developed for adults, you probably shouldn't apply it to a 2-year-old. As an example, the Nexus C-spine criteria were developed for awake patients with blunt trauma complaining of neck pain. So you can't apply Nexus to patients complaining of atraumatic neck pain, or patients that didn't sustain blunt trauma. Or as another example, the PERC criteria. This tool was developed for chest pain patients with a low risk of PE. What that means is that if your patient is high risk, like a patient who just underwent hip surgery 2 weeks ago, presenting with a unilateral swollen leg, hypoxia, and shortness of breath, then the PERC criteria probably shouldn't even be part of the conversation. So knowing who the tool was developed for and who it's appropriate to apply it to is the most common place where people go wrong. The other thing about clinical decision aids is that they were not developed to be applied to the population as a whole. They were designed to apply to a specific population in whom you have a specific clinical concern. If you're concerned that the patient may have diagnosis X, then apply a decision tool that is appropriate for diagnosis X and not for diagnoses A, B, or C. This comes up not infrequently when I'm having students present patients to me. One example that happened to me recently on a shift occurred when a medical student was presenting a patient who came to the ED for evaluation of right lower quadrant pain. I asked him for his plan, which included appropriate things like a urinalysis and a pregnancy test. But then he goes on to say that since the patient is tachycardic and on birth control, She fails the PERT criteria, and he wants to add a D-dimer, despite the fact that the patient had no complaints of chest pain or shortness of breath. The student was using a good tool, but was applying the tool incorrectly because we didn't have a suspicion for PE in the patient. This is why you need to have a suspicion of disease before you apply a decision aid. If I was to apply a decision aid to a room full of asymptomatic people, there are going to be some folks in the room that just happen to be positive for the tool. That doesn't mean that they need a workup, because the tool was developed for symptomatic patients. But this is how patients sometimes end up getting workups that aren't indicated, and we put our patients at risk of harm from unnecessary testing and overdiagnosis if we apply these tools incorrectly. Last of all, when it comes to decision aids, you can't mix and match. It can be tempting to take part of one decision tool and combine it with criteria from some other decision aid, but these criteria have only been clinically validated as individual decision instruments. When you start trying to use these tools in ways other than how they were developed and studied, that is hugely problematic because they haven't been validated or applied safely in this manner. If you're going to use a decision instrument, it's important to use it as it was developed and validated without adding or subtracting any of the criteria or combining it with some other decision aid. If you're going to remember anything from this discussion, please remember this slide here. Clinical decision tools are just that. They are tools. That's why I don't like to think of them as rules, because we all know that occasionally someone will show up with really atypical symptoms or an unusual presentation, or they may simply have other things going on that make the decision aids a little less applicable. Think of these decision aids as being there to support your decision-making and not to make your decision for you. These tools are not a substitute for good clinical judgment. There's a reason all of you have developed that spidey sense, and you should listen to it. If your gut is telling you something is off, go with your gut. As Oliver Wendell Holmes said, young men know the rules, but old men know the exceptions. And on that note, let's wrap this one up on clinical decision aids. Thanks so much for listening, and looking forward to seeing you again next time.